Good evening, everyone, and thank you for joining the Intellectual Disability Healthcare CPD webinar. I am Hannah Coffey, Intellectual Disability Program Coordinator, and I'm joined tonight by my colleague Clare Woods, Intellectual Disability Service Navigator with Central and Eastern Sydney PHN. We also have with us tonight co-facilitators Kylie Scott and Dr. Jessica Murphy. Kylie and Jess will introduce themselves in a minute. For now, I just want to note that the webinar is presented as a component of CESPN's GROW project, which is part of the federally funded Primary Care Enhancement Program. This is a pilot project currently being implemented across 4 PHNs in Australia. The program aims to give people with intellectual disability better access to appropriate quality health services that meet their needs. While I go through a few administrative details before handing over to our facilitators for the session, could I please ask anyone who hasn't already completed the pre-training survey to do so now? There is a QR code on the slide and the link will also be put in the chat by Claire. The Primary Care Enhancement Program is undergoing a national evaluation, which will inform future funding and ongoing support to primary care providers. These surveys have been developed by the evaluators, ABT Associates, and they are anonymous. We appreciate you taking the time to fill these out. I'm going to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. I'd also like to acknowledge people with lived experience of disability along with their carers and those in the sector that support them. Please note this webinar will be recorded and available on the CESPN YouTube channel. Please ensure that tonight, throughout this session, you submit your questions to the speakers in the Q&A function. To view this box, hover over the toolbar at the bottom of your screen. The chat box is also open if you would like to provide any comments throughout the session. We will do questions at the end. These are just a couple of updates more broadly around what CESPN is doing. So IARDST, the initial assessment and a referral decision support tool, is supporting mental health patients with care. Have a look at the free training for allied mental health professionals, practice nurses, GPs and GP registrars. You can scan that QR code for more information. Healthy Aging Hubs have recently launched in Gymea and Newtown, opening later on this month. And finally, here are some upcoming events. I'll just leave this slide up for a minute or two while you finish any of those surveys. And I will hand over now to my colleague, Kylie.
Thank you so much. My name is Kylie Scott. I am an artist. I run my own public speaking business, and I am an Olympic silver medalist. My passion, though, is advocacy. I have many personal reasons for this, but the main reason is how hard it has been and still is for people with intellectual disability to begin their lives, let alone thrive. From before we are even born, we must fight to prove that our lives are worthy of keeping. I have delivered messages on this to health professionals and politicians across Australia. But it doesn't end there. At the beginning, preventative healthcare plays such a vital role in our lives. People like me live to an average of just 54 years. I am currently 43 years old. I myself know and am aware that living with Down syndrome has health risks. It helps me if you make yourself aware of them too. Now, I'm sure you're all wondering, Kylie, what Olympic sport did you play to get a silver medal? Well, I represented Australia in 2 Special Olympics. the first in 2003 in Dublin, and then Shanghai in 2007. I won silver in Dublin in 2003 for tennis. I was able to compete because these Special Olympics were accessible and organized with an understanding that everyone has different access needs, even elite athletes.
We introduced you. We'll just introduce you. We'd like to introduce Jess Murphy, who's going to take over the rest of the presentation.
Hi everybody, my name is Dr. Jessica Murphy. I'm a GP from Leichhardt Medical and Dental Centre in Leichhardt. As you can hear, I'm originally from the UK. I did my medical training in the UK and also worked as a GP there before emigrating to Australia in 2018. I have a special interest in treating patients with intellectual disability, and in the UK I was responsible in my practice for completing annual health assessments for people with intellectual disability, and that's kind of where my interest started to build. And over the last year and a half, I've been working with the Project Grow to deliver training to GPs here and also to other providers for care for patients with intellectual disability. I'm going to pass back to Claire to introduce herself, and then we'll carry on with the presentation.
Hi, I'm Claire and I'm one of the service navigators for Project Grow at Cesspin. I've worked in the area of intellectual disability health and developing resources and training for the last 6 years. I'm really enjoying working with Project Grow and this exciting space of developing a project that will hopefully influence a national rollout. Thanks, Jess.
Thanks, Claire. Okay, so let's get started then. So the learning outcomes for tonight are as such. So we want to identify types of health conditions that people with intellectual disability experience, identify some key clinical resources to promote effective assessment of these conditions, determine effective health interventions for people with intellectual disability, and identify and implement a whole of practice reasonable adjustments. So we're going to actually start with a couple of case studies just to kind of get us in the mood about discussing the types of issues that can arise with these patients. So our first patient is Kit. Kit is a 51-year-old man who enjoys gardening and Star Wars. He lives with his mother, Sherry. His father, David, passed away last year, and he also has a sister who lives interstate. Kit's father used to drive him to work where he restocked shelves at a small grocery store. Since his father's passing, Kit left his job because it was too difficult to get there, and his only NDIS supports cover psychology services. He has a history of anxiety for which he takes an SSRI antidepressant, and this was first prescribed by a psychiatrist over 10 years ago. The dose has remained stable for the past 8 years. In the past year, Kit has become increasingly irritable, and on 2 occasions he's become aggressive towards Sherry. Sherry, who is 76 and has a history of osteoporosis, is concerned for her own safety and also for Kit's well-being. Kit has seen his psychologist 6 times so far this year to try to reduce his levels of agitation and discuss his behaviour management. However, it's not working, and they've come to us as a GP for further assistance. So my first question for you to have a think about is what could be going on here for Kit? What do you think are the potential differential diagnoses? We've actually got a bit of a poll question for you guys to answer. So Bertha, if you could put the poll on. I'm just going to give you a few seconds to have a look at that and submit your answers. Okay, I think that's enough time. Bertha, if you could reveal the answers for us. Oh, great. Okay, so overwhelming response of a grief response. Okay, interesting. So there could be actually a few things going on, couldn't there? There could be a grief response. It could be a worsening of his depression. It could be a physical health problem. It could be a medication reaction. You know, people with intellectual disability do have an increased risk of early frailty. So is this medication still reasonable for Kit 10 years down the line? Or could it be some other health problem? So what is the first thing that we're going to do here? Well, I'm not here to kind of teach GPs and practice nurses how to do the basics, but it's really important that we speak to Kit first. And the reason that I mention that is because, unfortunately, one of the most common complaints that patients with intellectual disability have is that the GPs don't address them first. They automatically talk to the person who's with them, their mum or their support worker or their dad or whoever's with them. And really, that's not the way to communicate with people. Even if patients do have communication difficulties, it's really important that we give them the common courtesy to say hello to them, to introduce ourselves, and to garner that and foster that rapport with the patient. So we should speak to Kit first. And like with any patient, we should ask him his consent to speak to Sherry as well. And of course, then we want to gather some more information about any recent symptoms he's had. And when we do this, when prompted, we actually find out that with Kit, we need to use a visual aid map to kind of get a bit of an idea of what's going on for him. And when we do that, we actually find that Kit has been experiencing some pain in his upper and middle abdomen and his head. But we're not sure how long that's been going on for. So the next question is, do we need to physically examine him? And should we do that now or should we do that later? Well, given that we've probably taken the time to communicate in his way using a visual aid map, we probably don't have time to do a physical examination now. And it would be better for us to not rush our consult and to get the most out of the consult. So it might be better to bring Kit back another time, and we can explain this to Kit and Sherry and ask them to book in a long appointment for next time so that we can properly do this. So we do this, and a week later they return for a comprehensive full assessment, and the examination actually reveals that he's got a distended abdomen and he's got some pain. So we decide to do a plain x-ray, and that reveals that Kit is really constipated. So we decide to prescribe a laxative and some exercise and then bring them back for a review. And when we do that, Kit actually shows some improvement. So what should we do now for Kit going forwards? Well, the next sensible step would be to bring Kit in to do an annual health assessment if he's not had one recently. And this is an opportunity then to kind of discuss any issues that might be arising in his overall care. And when we do this, it reveals that Kit hasn't seen a dentist in 18 months. And that's because of Kit's anxiety over the dentist. So some of the things that we could offer, we could give an easy read or video resource about dental care. We could liaise with the psychologist to address the dental anxiety and see if she can help us with that. We could look and see whether actually does Kit need a GA for his dental care. And if so, we can liaise with Sydney Dental Hospital, for example, to arrange that. And we can then also, and I'll speak a bit more about this later, organise any other outstanding tests whilst he's under GA. More broadly speaking, it might be worth doing an NDIS review for Kit to see if there's any more services in the community that could help. So, for example, an exercise physiologist to help do more exercise, a dietitian. Do we want some support workers to help with enhance his participation in community again? And then also going forward, just discussing preventative healthcare checks. And then finally, we need to remember Cherie's needs as a carer too, making sure that she feels safe in her well-being, and then also to discuss with both Kit and Cherie about future care planning as Kit may become more frail as he gets older. So why is this an important case study? I think it really highlights that missed health conditions are really common in patients with ID. So, out of the few people that responded in the poll, everybody at first thought it was a grief reaction, and that's not an unreasonable suspicion. But actually, when we dig down, we can find it might just be something really, really simple that's been overlooked. It also highlights some of the reasonable adjustments that we need to make for these patients so that we can get the most out of our sessions. So for Kit, he needed help using visual aids to help discuss things like pain. Another reasonable adjustment is the use of repeated visits and reviews that gives us extra time to communicate effectively with the patient and ensure that we're not missing things and we're able to engage them and develop rapport with them and build trust. It highlights the often overlooked carer and supporter needs, and also the role of annual health assessments, which are really important and I'm going to come to in a bit more detail later. By the way, feel free to kind of put any questions in the Q&A for later if you do have any points you want to make or ask about. So our next case study is Amelia. So Amelia is a woman in her early 20s who loves cats and enjoys watching cooking shows on TV. She has an intellectual disability and cerebral palsy. She's able to vocalize and use some sign language, but it's very difficult for people to understand her communication. It's Amelia's first visit with you. Her previous GP, who she saw since a child, has recently retired. Support staff inform you that Amelia has lived in their residential service for the past 3 years and she sees her mum every weekend. She has epilepsy for which she takes medication. She also has a history of trauma. As a teenager, she was sexually and physically abused by someone who was not a family member. And in recent years, she's had mental health problems, including a suspected suicide attempt. She's also exhibited behaviours of concern, including non-suicidal self-harm. Support staff report that for the past month, Amelia has exhibited sexualized behaviours, including taking off her clothes, exposing her genitals to staff, both male and female, and touching her genitals in public. And these behaviours are becoming more frequent. There's no changes in the group home or day programme when the behaviours began, and also no other signs of any mental health crises around them. So, again, over to you guys. So again, I'm just going to get you to think what could be contributing to Amelia's presentation. And again, we've got a little poll that Bertha can put up for us. And I'll give you a few seconds to have a look at that. Great, okay. And Bertha, if we could have the answers, please, or responses. Great, yeah. So as you can see, there's quite a few possible options here. You know, it could be that there's some further abuse going on. It could be her trauma response from previous abuse, or it could be because of her behaviours and communication issues. Or is it a physical problem? Has she had any recent changes to her medication? Has she had any new seizure activity that's been going on that's not been picked up? So again, what are our first steps? So again, not to just repeat myself, but we do need to speak to Amelia. We've never met her before. She's a new patient to us. We need to introduce ourselves to her. And even if she's not able to communicate verbally, we still need to acknowledge her presence and show them respect to saying hello. The other important thing to remember with Amelia is that she does not have the rapport with us yet. She has not met us before. Her previous GP, who she did have that relationship, has left. So we need to take our time to kind of foster that relationship with Amelia. Of course, we want to gather some information from carers and the family. We want to ensure that the support staff who is with her today can communicate and interpret her communication, and find out what consent arrangements are in place for Amelia, given that she can't communicate clearly. And then, of course, we want to maybe conduct a file review of what's been going on, and then get more information that way. Now, because Amelia is unfamiliar with us, again, it's probably not appropriate to start making her have an examination today. But in the meantime, we really, really need to make sure that she's safe. So this is really important to think about how we can liaise with group homes when patients aren't living independently. It might be worth discussing the staffing with Amelia. Does she need 2-on-1 for when she has personal care? And that might need to then have approval from NDIS for her package, which we can then provide support letters for it if we need to. And then reviewing her behaviour support plan as well. So as you can see, it's not straightforward, it is complex, but again, we need to take the time to do these things so that we can ensure that these patients are being kept safe. And this might take a few visits to do. Oops, sorry, I'm flicking through. Once we've had that initial appointment, we might then bring Amelia back in to speak to her more in depth. And then we can start to conduct a physical examination for Amelia. Now, it's really important to remember that Amelia's had previous trauma. So when we examine her, we need to be really mindful of this and think about how we can build and trust a rapport and think about approaching this in a trauma-sensitive manner. And also really important that we gain consent and document that consent process. Now, of course, with Amelia's communication and physical health issues, we might not be able to examine her genitally. Therefore, we might then decide, do we do a treat and see approach? If we think there's something going on there genitally, do we treat and see whether that works? So, for example, you could potentially prescribe some antibiotics for a UTI if we can't physically get a urine sample. Obviously, bearing in mind that we're not going to do repeated antibiotics, but I'm saying if she's not had one for a while. There is also the thought about opportunistic investigations and how we might arrange this for patients with intellectual disability. So, for example, I mentioned before with Kit that if a GA was required for a dental procedure for examination, for example, we can sometimes provide the team at the dental hospital blood forms, for example, to do a blood draw, or to use that opportunity when they're under GA to do a pap smear, for example. So it's about thinking around ways, around doing this in an opportunistic way rather than the bog standard way that we're used to doing with our routine patients. In the longer term, beyond this, it would be important to do an annual health assessment. Now, the reason I bring this case up in particular is that this was actually a true case. So Amelia had, in reality, consulted several allied health professionals and also GPs. And finally, when she saw the final GP, the eventual diagnosis was thrush. They treated the thrush and all her behaviours actually resolved. So again, it really highlights the fact that often common things are overlooked in these patients, but it also highlights the complexity. It's not straightforward from a communication issue, from an organisational issue, from an investigation issue. It is hard, but hopefully with repeated visits, with garnering trust and rapport, we can start treating these patients properly. And one of the key things that it highlights as well is that any change in behaviour with patients with intellectual disability needs to be assessed in this manner. So we need to think of physical health problems first, then think about mental health problems, then social and trauma environmental, and finally thinking about behavioural issues. And the reason for this is because, unfortunately, patients with intellectual disability are victims to something called diagnostic overshadowing. And that's where we mistakenly attribute a person's symptoms to their disability or to mental health or behavioural problem. And I think the last two cases really, really highlight this, because often we would think that, with Kit, it's a grief reaction, with Amelia, it's a trauma response, when actually it was bog standard medical problems that were very easily treatable. And if we follow this pattern of physical changes examination first, then we can then avoid missing things like this. And really, if you think about it, it's very similar to what we do in the elderly with a confusion screen. If patients present with new onset confusion, we automatically do a full confusion screen for them. So we should think about it in the same way for these patients too. So this is just a quick slide about commonly missed presentations or poorly managed conditions in patients with intellectual disability. And this was compiled by Professor Nick Lennox, who is at the Queensland Centre for Intellectual and Developmental Disability. So as you can see, a lot of these conditions are run-of-the-mill, everyday, normal conditions that we see in all of our patients. However, unfortunately, they can be really overlooked and poorly managed. And there's just a few extra here that happen as well. So I'd like to spend a bit of time now just discussing about the annual health assessments. I'm sure all of you, as being GPs and practice nurses, are aware of annual health assessments. And I'm sure that you're aware that patients with intellectual disability are eligible for an annual health assessment, and there's a Medicare item number for that, like the other populations. And I'm not again going to teach you how to do your job. You all know how to do an annual health assessment and what's involved. However, I just wanted to highlight a few things that are really important to probably drill down to in the annual health assessment for this patient population. And these conditions are things that often cause, according to our data in our area, cause the most hospital presentations for patients with intellectual disability. And they are respiratory problems, in particular aspiration pneumonia. So really important to assess their swallow and their feeding behaviours. Epilepsy management is a huge one. So uncontrolled epilepsy and presenting to ED with seizures. Oral health is a massive one because we know that this population has quite poor oral health, and that, as you all know, can lead to other risk factors with infections, heart problems, etc. Immunisations, often immunisation histories or immunisation records are incomplete, and therefore we do see a large burden of admissions with immunisation related medical problems. And then finally, two problems that aren't necessarily related to increased admissions but are also poorly managed are sexual health. Often, I think as GPs, we don't really feel confident in bringing up sexual health with patients with intellectual disability, and therefore we just don't mention it. But we need to get over that and learn how to do it, because unfortunately, as we've already looked in Amelia's case, often these patients can be victims of sexual abuse, or they might just be becoming sexually active and, like any other patients, may be at risk of sexually transmitted infections, unwanted pregnancies. So we can't just ignore it. And towards the end of the presentation, we will talk a bit more about resources, and we can certainly share some resources about these things as well. The other thing that I wanted to touch base on with annual health assessments is logistically how we can do this. And I know a lot of you are probably sat there thinking, well, this is all well and good, Jess, but how do you expect us to do this when our Medicare rebates are so poor? And my advice with that is use of repeated visits, especially for annual health assessments. So I recently contacted MBS Online about this issue and asked, how can we bill with repeated visits so that we avoid getting audited? And their response to me was to break the annual health assessment up into several visits, and then at the final visit to bill for the total amount of time completed for the annual health assessment, which, let's face it, for the majority of these patients is probably going to be a greater than 60-minute annual health assessment. And that's absolutely fine to do, and is above board with Medicare. And currently, as within our team of Project Grow, we're currently doing some training with supported independent living. Is that the right way, Hannah? Supported independent living providers in the area, in the region. And that's to explain to support workers how they can best work with GPs to get these annual health assessments done, and to put a plan in place of then how to follow these patients up regularly and make it more streamlined when they're booking appointments with the GP. So one of the things that we're going to suggest to them is actually using telehealth more. So using telehealth prior to annual health assessments so that they can discuss what might need to be brought to the appointment or anything that needs to be done in advance, such as blood tests or assessments of some description. they're also then going to be given a strategy of starting to compile information for the annual health assessments a few weeks out, so that by the time they come to the appointment, some of it will already be done for us. And then also educating them about the use of GP management plans as well, because a lot of patients and support workers aren't aware that GP management plans exist. And as we know, that is actually a really useful tool to get on top of overall health conditions. So one of the ideas that I had of how it might work is you do your annual health assessment. If you've got time, you can co-bill for a GP management plan on the same day. So you could potentially then fill in a GP management plan with the goals that you found at the end of the annual health assessment, or you could bring them back, say, a week or two later and prepare a GP management plan, if they're eligible, of course. And then you've got then a set structure for your GP management plan review throughout the year, either 3 monthly or 6 monthly reviews, depending on complexity, that you can bring them back and check that things are being done. And the idea behind doing it that way is that we're going to stay on top of these minor issues that keep cropping up, and therefore hopefully reduce the need for ad hoc standard appointments that we often run behind on or are difficult for us to manage in 10 to 15 minutes. It will then also hopefully reduce hospital presentations, which can be very, very stressful for these patients and for the carers. And hopefully we'll get on top of these general medical things that need to be done. The final thing that I want to mention before I move on is coding. Coding is really, really important. And I think Claire's going to talk about this a little bit later. But we want ideally coding to be done with both intellectual disability, if the patient consents to that, and the syndrome specific problem, for example, Down syndrome, because that can really help us when we come to start doing some QI work, and Claire's going to explain that a bit later. I'm going to also just highlight some options for annual health assessments. There's a government one here that's from the Department of Health, and also there's the CHAP tool, which was again produced by the University of Queensland Centre for Intellectual and Developmental Disability. At the end of the day, it doesn't really matter what document you use. You might already have your own inbuilt document into your system. As long as they're being done, then it doesn't matter what plan you use. Brief overview of item numbers. I'm sure you're all familiar with this, but the one I really want to draw your attention to, which is one that I didn't really know about until doing this work, was the case conference item number. So this can be billed. The GPs can organise a case conference and bill for it, or you can bill for it just by participating in a case conference. According to Medicare, there needs to be a minimum of 3 health professionals in that discussion, and that can include people like allied health professionals or support workers or nurses, but it doesn't include the patient or the carer. So the patient or carer can be there for the case conference, but they're not included in the 3 people. And usually this is done for a patient who's on a GP management plan, and then can be done up to every 3 months as needed. I'm going to skip through this case study in the interest of time and move on to some resources that I want to highlight. So the first one is about polypharmacy. As I mentioned, it's really common in people with intellectual disability, and we need to consider the anticholinergic burden, especially for people with Down syndrome, because they're at risk of as we know, at risk of Alzheimer's disease, and also they are at risk of cardiovascular problems, which these medications can compound. I wanted to highlight this resource, which is actually from the NHS, and that's called STOMP, and it's about how to kind of stop and reduce medication and polypharmacy. Second resource I'm sure you're all familiar with is therapeutic guidelines. They do have a suite on developmental disability. So that's worth having a little look at. And then again, I'm sure you're all familiar with Sydney Health Pathways. So the usernames and passwords are there in case you don't use them, but they also have a full suite on intellectual disability pathways, which are these ones that I've just put on the screen there. And within them, they have key contacts and referral pathways for patients. Again, some really helpful resources there if you're not sure where to go to in the community for these patients. Finally, I know that some of you may have come to this presentation tonight wanting to know about syndrome-specific health risks. The reason I haven't gone into that is just because it's just too vast. It's, there's so many different syndromes and they have different health risks. We'd be here all night. But this link here, and again, this is recorded so you can access it later, does have some specific health risks within that you can have a look through if you want to know more about that. And finally, before I shut up, the last one that I've got is just about specialist intellectual disability health teams within our region. So these teams are they don't have a finite resource, so it really is for patients who are more complex, who have unresolved health issues, or maybe if you need help with diagnosis. They can help with developing and coordinating referrals and health plans, but we shouldn't be referring them for bog standard everyday problems. We should be more than capable of managing that as ourselves as GPs. So please don't overburden them with simple problems. But if you do have a complex patient, they will help you, and please feel free to reach out to them. And their contact details are there on that page. So I'm going to stop talking at you, and now we're just going to play a video from Dr. Vanessa Sarkozy, who's going to talk a bit more about the transition from GP and tertiary care.
Hi, my name is Vanessa Sarkozy. I'm a developmental paediatrician at Sydney Children's Hospital in Randwick, and I'm currently head of department.
Sorry, bear with us.
At Tumberton, which is the child development service based there. I think there are two populations. There's the population that really knows their GP, and their GP is their care coordinator. And then there is a population who doesn't have that relationship with a GP. And I think they have very different models of care. And that perception that the paediatrician or the specialist is the person that manages that disorder becomes more and more entrenched over time. I think the much more optimal model is that the care coordinator is the general practitioner who then pulls in additional resources as required. And as specialists, we reinforce that idea that the GP is the first port of call, and if the GP is worried, they can contact us and we can escalate that way. So like everybody else, we have a finite resource, and it's nice to target the resource to where it's best used. It also concerns me that families often wait an extended period of time to come and see the paediatrician with disorders, conditions, concerns, which would be much better managed and much more managed in a much more timely way at the general practice, be it warts, constipation, gastroesophageal reflux, etc. By deferring care, I think that that's not the optimal outcome for the child, and it also reinforces a message for families that they have to see a specialist. And actually what those families need across all chronic disorders is a tiered approach. So they need to have a general practice who has that overview of the child, overview of the family, who understands the history and is then able to pull in additional specialist resources as and when required. I think that's the best use of health resources, but I also think it's the most appropriate model of care for families. It means they can rapidly access care when they have concerns, they have confidence in their GP, and their GP has a mechanism for pulling in additional resources or support as required. So I think there's delay. I think that's probably the most important issue. The routine healthcare is neglected, so we see conditions presenting far later than they needed to. So our capacity to change the trajectory is diminished. Some of that comes from a perception that disability is not health, or that these children are not unhealthy, which often they're not, but they're at risk of poor health, and that sort of changing that conversation for families. But my primary concern is the delay in accessing care. So if they're seeing a paediatrician every 6 months, every 12 months, that you would defer management of a treatable condition, or even assessment for a significant condition that should be actioned much more quickly. GPs sit in a unique space within our system, so they are often the person the family first approaches when there's a concern about language development, learning, etc. So they're aware of the initial concerns, and in an ideal model, they would then continue to carry the family whilst we did the assessments, and if we have a definitive diagnosis, we communicate that back to the GP. The GP is aware of that, and we shift from a diagnostic phase for the family to a long-term care phase. Families with children with disabilities are often highly stressed. We know that family relationship and breakdown is much more common in families where there is a child with a chronic health disorder or a disability. Having care for the whole family means that I think that the child gets better care. So having someone who understands what's happening with the sibling who maybe has developed another disorder, an elderly relative, parental mental health, family breakdown, things that are not always shared with a specialist, means that the GP is in a much better position to understand the dynamics, what's reasonable to ask of the family, the degree of stress the family's under, and when the family needs additional supports. And that may be not within my power to provide, but certainly as a paediatrician, one of the jobs you do is advocate, and I do appreciate that we have more time for that, and we have access to social workers, etc. But knowing from the GP that the family is really under stress will direct what I then decide to do with the family, or what additional resources need to be brought in to support the family, and that additional communication, that information that the GP holds that no one else has, is critical to the long-term well-being of the family unit, and therefore the child. What I see too often, not just with general practice, but also with paediatricians, is that families stop coming. They have an answer. It's very clear that the doctors can't fix it, and therefore there's no real reason to engage in healthcare. And what we know is that with routine surveillance and health promotion, certainly in adults, we found many more health disorders which we can manage, optimize health and well-being, and I believe the same is true for children. In an ideal world, that shift to managing the child as someone with a chronic disorder means that they would get annual check-ins. You would build up that comfort for the child within clinic to have their blood pressure taken, to have a look in their ears, be weighed and measured, all the things that you really need the child to be able to tolerate as an adult to be able to continue to provide that care. It also allows for early intervention when there are problems found. So I think it's important that the GP and the family understand that there are health issues associated with developmental disorders and intellectual disability, and that connection with the GP is core to the ongoing well-being of the child and family going forward. And we shift from that investigative and diagnostic phase to a long-term health promotion and surveillance phase. From my perspective, it's very different if you know the child from 2 and 3, they grow up with you, you learn about their interests, you're able to put them at their ease, you have that connection going forward. Then if you suddenly meet someone who's 15, who's bigger than you and potentially aggressive, it's a very different relationship, which again speaks to why that continuity of care with a GP is so important. Generally, I follow other people's leads. So if the carer comes in and the child is agitated, I would ask, what can I do to make things better? There is no one answer for everybody. It is an individual response. Sometimes it's the light in the room is too much. Sometimes it's the noise. Often waiting makes my patients very agitated. So certainly this is a population I work really hard to run to time for. They don't like hanging around in my waiting room. They don't like change, they don't like seeing different doctors, they don't like being in different rooms. So as much as I can to minimize that, and really working at the child's pace and understanding that, you know, it might take me 4 or 5 visits before I can actually get an accurate blood pressure, which is why it's important that I start taking a blood pressure when it's not clinically vital that I get a correct blood pressure. It's a skills development with the child. So we put it on mum, and then we put it on the brother, and then we do it on the child, and we do it by palpation, and then eventually we get an accurate blood pressure, and the same with weights and heights and ear examinations. There has to be a really good reason, a clinical, acute reason why I would push a particular component on an examination on a child. To me, it's much more about building comfort, and coming to see the doctor is not a scary thing. Some families like to have video, photo diaries. I mean, all sorts of iPad stories where, you know, we're going to go see Dr. Vanessa, and they know that Dr. Vanessa makes you weighed and makes you measured and takes your blood pressure and feels your tummy. And they can have that conversation, and they can do that pre-warning with the individual child. But mainly, it's just a matter of familiarity, of coming often enough and regularly enough in a predictable way that the child and the family feel comfortable.
And over to you, Kylie.
Thanks, Jessica. Okay, I have a regular appointment with my GP, so I don't have to remember to book. We can do this because I have a chronic disease management plan. Many people with intellectual disability have other underlying health conditions or health risks. My GP found this a great way to see me regularly, to deliver the preventable health care I talked about earlier tonight. Because these appointments are regular, my doctor can spread out complex and involve consultations across them, so I don't feel overwhelmed. Another advantage to recurring appointments is I know in advance when to book my NDIA support. For appointments that sit outside of my regular one, I get the practice and send all communication directly to me as well as my mum. This is an important point for so many people with ID, sharing this responsibility with their support person, my medical advocate, that I nominate not only helps me, but it means there are fewer missed appointments in lost billable hours. As I mentioned before, with Down syndrome, I am at high risk of heart conditions and Alzheimer's. Research suggests that about 50% of people with Down syndrome develop symptoms of Alzheimer's disease after the age of 40 years. How do you prepare me for this? Aside from talking with me about it, be aware of my baseline cognitive ability. This means annual health assessments are important to start at an early age. Help me understand what I can do and engage health professionals who can help me embed the needed preventative lifestyle changes. And as just mentioned earlier tonight, diagnostic overshadowing happens a lot of people with ID. So try to exclude other medical conditions like a UTI before diagnosing Alzheimer's. Research published last year shows that people with ID have low vaccination rates and are admitted to hospital for preventable illnesses greater than the general population. Choice and control are important for people with ID. For us to practice this, we need help to understand the why and the how. As Dr. Vanessa mentioned, take the time while we are young to explain the why and how, build a trusting relationship, and we can feel properly prepared and empowered. This will lead us to make informed medical choices and decisions around important things like being vaccinated. People with IID have different abilities and ways of communicating and understanding of what's happening and being said. So please keep in mind that most of us can and do understand what's happening around us. Just because some of us can't speak verbally or communicate with our bodies doesn't mean we don't get scared, confused, or angry that something hasn't been explained to us. I know of and use resources made to help explain the process leading up to procedures, hot topics. They have charts that help express pain or emotions. Claire will speak more on this in a minute. Another thing to keep in mind, for example, when prescribing or referring, is to not take for granted that I know the process. I was recently prescribed some medication. The prescription was for half a tablet daily. My GP didn't mention I need to cut the tablet. So, when my mum picked up the prescription, she had to ask the chemist what I needed to do. They showed her and gave her the cutting implement. If my mum didn't pick up that medication, I'm not sure how I would figure it out myself. I got some rough patches. I was treated like I was stupid at a job I had. And 4 years ago, my dad died 5 years ago. I also, like everyone, struggle with life sometimes and need mental health support to get me through. Having an intellectual disability doesn't mean I don't have ups and downs. Having an intellectual disability doesn't mean I don't understand when I'm treated differently and take it too hard. I see someone for my mental health, and they have helped me through some really tough times. Before I hand over to Claire, I just wanted to say thank you for taking the time to attend this training. And I ask you to encourage your colleagues to do the same. The more health professionals who attend training like this, the more inclusive the health system becomes for people like me. And while inclusion may seem like a hard thing to get right, just imagine a health system full of people who don't even try. For me, not worth thinking about. So, again, thank you for coming tonight. I now hand over to Claire. Mrs. Clare Woods.
Thanks, Kylie. And what a powerful call to action. So thank you. As mentioned by Kylie, changes, even minor ones, to your practice can have a massive impact on not just a patient feeling your service is accessible, but it has a cumulative effect on people's long-term health outcomes. We could talk for hours on all aspects of communication and communication tools. And I saw that there was a question in the chat earlier, which I hopefully will answer within my presentation. And we're pretty lucky to live at a time where if you're looking for a communication aid, more often than not, someone has had the same issue before you and created a resource for it. We at Grow straddle an interesting line in our work. Our project is influenced by people like Kylie with lived experience and their needs and requirements to fully participate in their healthcare, along with preventable deaths and hospital admission research. But it's also influenced by the realities of the Australian healthcare system, an industry that we understand is struggling on multiple fronts, having just gone through, hopefully, the worst of a pandemic and the complexities of running a business. So our job is to find ways to embed reasonable adjustments into practices that make it easier for all parties. A tough ask, but we feel confident that we've developed a solid program of information and support that fosters these changes. Grow, as I mentioned earlier, is funded by under the National Roadmap to improve the health outcomes of people with intellectual disability. Our team have been developing this program for 2 years now, and all the training and activities are based on studies such as the ones published by UNSW and QUT. They're also guided by the people with lived experience, their feedback, and also the feedback that we've received from GPs and practice staff. Elements of our program are the training that we're here tonight doing. We also offer in-practice training, which is more of a case-based training where GPs and other practice staff can talk through appointments that they've had or issues that they've had that they haven't quite figured out or haven't known how to figure out what to do. We do it on a very kind of ad hoc conversational basis. We also have service navigation, which is myself and Jen, and we support anyone from allied health to general practice to service providers, with linking them in with local services. One of the most requested things is for people to be assisted for assistance with supporting practices or medical professionals to connect patients with the right local services, which often for us is a learning too. But what we're discovering is that there are lots of amazing services within our region, and we're really lucky to have the abundance of funding in this space for intellectual disability health. We also have an element which we built into the project about a year ago, which was around community engagement. Knowing from previous studies by Nick Lennox, who's been mentioned already tonight, his research into how to get the best uptake of annual health assessments, and his research said that you can train GPs and health professionals as much as you want, but you can't guarantee that person will deliver annual health assessments to all their patients with intellectual disability. You're better off giving the tool to the patients themselves and letting them bring it into the GP practice, and 99% of the time you'll probably get the annual health assessment. And another element which I'll talk about shortly is quality improvement activities. So I've been asked to talk about reasonable adjustments. So what are they? They are accommodations that are made to ensure a person with disability has full access and participation in their healthcare. The most common and well-known are the physical adjustments, but adjustments can be tweaked all over the place to make conversations, systems, and spaces more accessible. Some adjustments could be, like we talked about, the physical, so that's environmental, sensory, visual. Another adjustment could be that working with parents or the carers or support staff and consulting with them. Those are the people that know the individual best to ascertain what accommodations a patient might need. For example, patient A is triggered by X, and they'll be able to tell you that Y is the thing that will calm that person down. Engage with the person, ask what adjustments they need. The biggest reasonable adjustment request that I've heard from people and in conversations that I've had is that they want clinicians to make eye contact with them and direct questions to them and not their carers, even if it is the carer who's doing most of the talking. Another adjustment is team communication. It helps that all practice staff are across the relevant reasonable adjustments, and to provide training and professional development on intellectual disability healthcare. And our project can help with that. Another adjustment could be system and process, and we'll talk more about this on the next slide. As I previously mentioned, we've been working with the supported living, independent living providers, and Jess has mentioned this too. And one of the things that we're developing with them, along with the process around annual health assessments, is a one-page reasonable adjustment profile that people can take to their appointments that will specify what are the reasonable adjustments that that individual needs to have a safe and inclusive appointment with you. So, as I mentioned, systems and process. It became apparent early on that tonight's level of training provided to clinicians was gave a good understanding of the what and the why, but it didn't really provide or demonstrate realistic examples of the how, or an opportunity to really provide the support to foster cultural or behavioural changes within practices. So we are, along with practice support and digital health, developing QI activities that support practices to make small tweaks to practice software and to behaviour that enable better management of the life-saving preventable health interventions needed for this cohort. The first activity is to identify, as Jess said, is to identify all patients with ID and uniformly code them. What I might do now is ask you to put in the chat what you think the benefits to identifying patients with intellectual disability and uniformly coding them could have, and what would the benefits be? I might give you a minute to put some of that in the chat. Hannah, I can't see the chat, so you might have to kind of come on and let me know if there's anything in the chat.
Jess is whispering answers to me here.
My idea is that it would benefit for when patients are referred elsewhere, if they get admitted to hospital, if they see a new GP, that it's easy to identify straight up that this patient has an intellectual disability, because if it is a more rare condition that they have, not everybody might be aware what that is. So if it's uniformly coded as intellectual disability, then it's quite obvious that people may need to use reasonable adjustments or those things. That's my idea.
Thanks, Jess. That's great. Yeah, creating a register or a list within your practice as well, and agreeing on a specific coding can improve the identification and allows the practice to know how many patients you have with intellectual disability. And for most practices, that won't be a huge cohort. Cleaning up and ensuring everyone is correctly coding the active diagnosis. We've had a few conversations with Vanessa, who was in the video before, saying that lots of people over the age of 5 are still coded with having a global developmental delay. The DSM-5 says that nobody over the age of 5 should be, because they're old enough to be able to kind of perform those diagnostic testing to ascertain what the actual diagnosis is at that point. And yet when I did a search on our Polar through one of our data services, I saw that 2/3 of the active patients with global developmental delay within our region were over the age of 5. So it's about just cleaning up the data as well. It also will allow practices to tweak how recalls and reminders are sent to give the confidence that they will be understood and actioned. If you have to think about, if you think about each of your patients with ID, are they able to read? Are they better with verbal instructions? Or do they need a medical advocate to receive medical correspondence? Also, what is your legal responsibility when you send out a recall? Does the person need to be able to understand what you've sent them and action it themselves? And we can tweak within the quality improvement activities, how that is, how you record what that person needs that recall to be. And it also ensures all annual health assessments, immunisations and screening is up to date because you've got a list that makes it easier to look at. Many barriers to accessing healthcare can be overcome with a little bit of flexibility in appointment systems, effective communication, and the provision of accessible information. Most of these reasonable adjustments don't cost anything, and an audit that you do can be put towards your CPD requirements. Other important adjustments are understanding these stats, services, and resources that can support and complement your work and nurses and GPs. So mental health. I think we've touched on mental health a little bit tonight. I just wanted to say that just to add to that, which is that the New South Wales Mental Health Commission reports that approximately 125,000 people in New South Wales live with an intellectual disability, and up to 40% of those people will experience a mental health condition within their lifespan. And unfortunately, there are very few services that offer mental health care to complex patients at low to no costs. But excitingly, Sane Australia recently launched a service for people with complex mental health care needs and offer online counselling and peer support services. They have received 240 referrals since their launching in May last year, with over 50% of them being self-referrals. They have capacity to support many more people and will respond generally to referrals within 1 to 4 days. We're also lucky in our region to have the Specialist Intellectual Disability Mental Health Outreach Service, the 2 statewide intellectual disability hubs, intellectual disability mental health hubs, to help people with intellectual or developmental disability access appropriate mental health care. One hub is for children and young people, and one hub is for adults. Both are funded by New South Wales Health, but referrals need to be referrals are needed to access the hub service. It can be made by a paediatrician, child psychiatrist, or child and adolescent mental health service, CAMS clinician. The hubs offer a combination of face-to-face support and virtual care, specialised assessment, care planning, reporting and recommendations, education training, and support for mental health clinicians and disability workers providing care for the people with intellectual disability. We've touched on it a couple of times tonight, but I know Jess just spoke on it, but the data presented to the Disability Royal Commission in 2021 stated that 90% of women with an intellectual disability have been sexually abused. Evidence also suggests that compared to women without disability, women with intellectual disability do not access cervical screening or breast screening at the same rate. Or an older study even suggested that less than 10% of this population have regular cervical screening. They have poorer reproductive and sexual health outcomes and lower levels of HPV vaccine coverage. Women with intellectual disability also experience a lack of education and support in relation to menstrual management, contraception and screening. This has implications for access to contraception, cervical screening and STI screening, prenatal care, and places them at risk of worse health outcomes. Primary care providers have a key role in addressing these disparities and ensuring women with intellectual disability receive appropriate education and preventative health care. But luckily in 2018, Family Planning and Cancer Institute of New South Wales joined forces to develop the Just Checking project. Just Checking resources aim to increase the confidence of clinicians in having conversations about sexual activity, cervical, breast and brow screening with their patients with intellectual disability and autism. These stats still shock me. So I just want to ask you to remember these numbers when seeing your patients, especially women, and ask you to engage in trauma-informed care when talking with them. Communication resources. We cannot emphasize enough the impact, early childhood approach, we cannot emphasize enough the impact early childhood intervention has not only on the child, but also the family unit. These services can encompass more than medical intervention, referring families to early childhood approach partners, which used to be the early childhood early intervention, or the ECEI. They can mean that a family get a bit more support to hopefully help them stop buckling and breaking under the commitments involved in raising children with complex care needs, as a large part of the work that they do is building the capacity of the family to support the child. Children under 7 who have a diagnosis or do not fully meet the definition of developmental delay, but have developmental concerns, will be supported through the early childhood approach. And if it's deemed appropriate by one of the partners or the support person, they can assist that family to get an NDIS package for that child. Yeah, I've included some videos on this which will be sent through in the package that Bertha sends in the next couple of days. Feel free to watch that. Our partners in this region, for most of you, is LifeStart, but also in the Canterbury area, each of the support partners. Communication resources. There are many ways to adjust the way that we communicate with people, and many tools have been developed to assist in health settings. I've linked a few locally made tools to assist with self-advocacy, supported decision-making, and how to have and supporting hard conversations. Research shows that many people with intellectual disability encounter death without being included in the process, be it when a family member is dying or when they themselves approach death. Many people don't know what to say and don't include the person with intellectual disability in the conversation. This can be extremely stressful, ostracizing, and hurtful, and potentially dangerous for the person with intellectual disability. But luckily, like I mentioned before, if you Google, someone has come up with some resources to assist with those conversations, and I'll link them into the slides. I was at CID before I came to CESPN, and I was privileged to help create the My Health Matters folder, which is a communication folder that includes a variety of communication tools that can assist in many different styles of communication, from pain scale to a mental health elevator. And similar to this, the admission to discharge folder, which is mainly used in SIL or group homes when accessing hospital. Someone asked before around visual aids. Everyone's really different with what they need to help facilitate those conversations, but if there are particular procedures, ACI have developed the Say Less, Show More suite of resources, which are social stories that talk through a procedure like getting a vaccine. And there are many resources, too many for me to name in one session, that can help with the communication. But it's best just to ask maybe the person that you are treating whether they use aids, and if not, what would help foster a better conversation for them. CID, or the Council for Intellectual Disability, have created and will continue to create health resources in this space for both professionals and for people with intellectual disability. So there's a link to the resources that they have developed so far, and they are still developing suites of easy read resources that talk through common things like dental care, etc. This last part, I'll not go into much detail, as I'm sure you've hit the information overload if you haven't already. But within appointments, there are so many ways to adjust practices and communication. A reasonable adjustment can be as simple as asking if your patient understood what you just said. A good way to understand whether they do understand is to ask the individual to give you a summary of what they understood you to say. Supported decision making. We start with the assumption that all people have the capacity to make their own decisions. At times, everyone needs support to make a decision. For example, advice from the hairdresser about hairstyles or advice from a lawyer around legal issues. People with intellectual disability are expected to make their own decisions and should be provided with the support they need to do this. Within appointments, break down concepts. And as I've mentioned, use visual aids when possible. On one of the previous slides, I linked to the Say Less, Show More resources. As I said, they're great resources, and you can make your own. If it's a procedure that you know that you're going to have to explain more than once. In some cases, it might be worth considering meeting patients or the participants with known behaviours or sensory issues outside of the practice. I know some GPs that they're known patients, they will go and see them in the car if it's appropriate, to stop them having to having to face the anxiety of being in a waiting room. Offer telehealth or video health or home visits to eliminate the risks of waiting room disruption or unnecessary stress on the patient. There are many barriers that prevent this population receiving effective healthcare, and everyone is different, has different adjustments they require. Our take-home message with this patient cohort is that there are no one-size-fits-all approaches. Most practices will only have a handful of patients with ID, so it's worth taking the time to ask. And not to blow our own horn, but attending this training is a great first step. Talking with your patients with ID and asking them what would make your practice or your consults more accessible, and conducting annual health assessments is a great place to start. As mentioned earlier, the GROW team has the capacity to provide in-practice support to implement strategies and workshop solutions for your practice, and help you with quality improvement activities, whether they be individuals, group homes, or a significant patient cohort. We can assist. So we could assist with upskilling clinicians or admin staff. We're happy to do any of that support, and we're contactable by phone or email. Thanks, Hannah. I think we're at the question stage, so I'm hoping that I've answered the questions that have come up.
Thanks. Yeah. Feel free to keep putting your questions through or any comments in the chat. We do have a few questions here, so and they are directed probably a little bit more at Jess. What strategies or tools do you recommend to effectively assess mental health conditions in people with intellectual disability?
I think it's a tricky one, and again, it kind of comes back to that everybody's different, and it kind of does depend on the patient and what rapport you have and how complex they are. But I think I had to kind of take an approach of initially asking the patient how they're feeling, and potentially using, like Claire was just showing, the visual analog scale, the mood elevator scale, for them to highlight to you how they're feeling. But then also using, hopefully, if they present with a carer or support worker, a collateral history about perhaps what previous mental health issues they may have, or what behavioural changes they're noticing in the patient, to kind of then build more of a picture up of it as a whole. The bit that I actually don't know, because I need to do some training myself, is about you know how when we do mental health plans, Medicare stipulates we should be doing an assessment tool of some description, like a K10 questionnaire or a DAS-21. That's the bit I don't know, is whether that exists. But I think, Hannah, you were going to talk about some training that's going to go on later in the year about this.
Yeah, so to complement this sort of this broader introductory intellectual disability healthcare event that we're running at the moment, we are looking at doing a bit of a deeper dive and producing a CPD series. So this is I guess more specifically targeting GPs, but it really is relevant to practice nurses as well. But it will go a little bit deeper into a few key areas. One of those being mental health, specifically around those assessment tools and how to really do a thorough mental health assessment within primary care settings, what tools to use. We will be looking a little bit more into polypharmacy as well, the use of Medicare item numbers. So there'll be some more information that comes out about that in the coming weeks, and an opportunity to register for that. So we can look a little bit deeper there. One of the other questions that we have is, how can practice nurses support GPs with this patient cohort, either with annual health assessments or just regular health appointments?
I mean, I think, again, it depends how your practice is run. I know in our practice, we utilise our practice nurses a lot to help us do some of the legwork for annual health assessments. So we might get the patients to come and see the practice nurse first to do some basic data gathering, like, for example, doing the blood pressure, the height and weight, doing some of the more questions that can be answered with the support worker about their social aspects or their mobility and those things. And also, if a patient's on a GP management plan, there is the item code. I think the item code off the top of my head is 10997, but I have to double check the actual numbers. But that actually gives access for patients who are on a GP management plan up to 5 visits with a practice nurse for healthcare needs. So that could be really helpful when you're bringing them back for those routine checkups, that maybe that could be utilised that way, and practice nurses can help to reduce some of that burden on the GPs. Another way that can be really helpful with practice nurses is for them to liaise with GPs in advance of the annual health assessment, so that we're all on the same page about what reasonable adjustments need to be done for the patient. So that, because again, I know as practice nurses, often you do get burdened with a lot of this work, and the GPs do the final bits and the sign-offs and things. So, you know, I think working collaboratively as a team to prepare you guys as well is really important, and we can maybe then give you a heads up of what maybe the key things we need you to focus on when you're seeing the patient. So I think just having that conversation before the patient even comes would help to streamline it a bit more, really.
Thanks, Jess. We haven't had any other questions come through, so I'm just going to whisk through the last few slides. If there are any, please feel free to add them just in the last few minutes that we have. So as we mentioned, GROW's intellectual disability healthcare training is delivered by this traditional CPD format, but then also, as both Claire and I have mentioned, through in-practice training, and that can be tailored to the practice, who will be there, whether it be admin staff, practice nurses or GPs. We also offer that to allied health staff as well. So if you would like any further information about that, please don't hesitate to get in contact. We'll be circulating some information with the resource pack after this session. As always, our service navigators, so Claire and Jen, are available Monday to Friday for any of your service navigation needs, whether that be finding a specific service relevant to one of your patients within our region, but also with any resources. As we've sort of really emphasised, there is so much information out there, and if there's anything that you can't find or would like more information about, please don't hesitate to reach out. As I said, and as Claire mentioned, if we don't know of it, or if we don't know about it, it's a prompt for us to go dig in, and that's exactly what we're here for. That's what we're funded to do. So any call, any inquiry we'll take, and we'll do our best to support it. And we're really well linked in with our tertiary colleagues at both Sydney and South East Sydney LHD and the Sydney Children's Hospital, who again are really, really eager to support the primary care sector with this population group. So please don't hesitate to get in contact if you need anything. An evaluation survey will pop up at the end of this session. This is just a short one for our benefit, but as I mentioned, there is also an external evaluation being conducted by ABT Associates. This, as I said, will support ongoing funding, both within our region and nationally. So we really appreciate you taking the time to do that. Please don't hesitate to reach out, and thank you to all speakers as well as attendees. We really appreciate you taking the time to learn about this patient cohort. Thank you very much.